which is pan-RAS inhibitors in pancreatic cancer, but I'm going to talk about RMC-6236 that we've discussed some of the latest data that was publicly revealed recently. So these are disclosures. So, I had the slide from last year. This is from Jordi Rodon, one of my colleagues in phase 1, that these were the undruggables. This was when I first started my not my fellowship, but when I first joined Anderson about 7 years back. This is a slide I used to show all the time. And I'll show you some follow-up slides at the end about what I mean by this. So think about, one in the middle, Sylvester Stallone. So just remember that guy, because there's a follow-up coming. So there you go. So cracking KRAS, I talked about it yesterday. I don't need to talk about this. This is the mechanism of action of the RAS-on inhibitors that Paul just described really well just a few minutes back. This is the cartoon though. So this is the fancier part. Sorry, Paul. I knew, I thought I'll bring, so there's steric hindrance there. You see the steric hindrance there. It'll keep on a loop unless I move on. But this is the compound. This is the preclinical data of the RMC-6236. You have all the hotspots, Q61, G12, and G13. If you see the in vivo models at the bottom, it shows tumor regression. And obviously, there's durable progression-free survival in KRAS G12X PDAC models. So good preclinical data for this compound. This was some of the data, the phase 1. Scott showed some of the data, but this is for the PDAC data. Again, there is a lot of data on this, about 171 patients, treated with PDAC. Again, there are different dose levels, escalation doses, and I'll talk about this Resolute 302 trial at the end. The dose is 300 milligrams. That's kind of the recommended phase 2 dose. And I'll talk a little bit about how this dose is being used in future trials. So this was the patient demographics. Again, the ones that they took was from 160 to 300 milligrams because that's the kind of the effective range of the drug. The median age was 64 years of age. But if you look at the prior anti-cancer therapies in the metastatic setting, 2, so that's pretty high in pancreatic cancer. And about 54% of patients received one prior line of therapy, and 68% had liver metastases. So, and that's a very important point because we always talk about there's an indolent group in pancreatic cancer. So BRCA1, 2, KRAS G12R patients who have lung-only mets, who don't have liver mets, they can have a better prognosis. But as you can see, about 86% of these patients did get had liver metastases at baseline. So so kind of a population for our pancreatic cancer patients. So this is the graph which was shown before, and I just want to pause a little bit. If you look at this graph, when they presented it last year, it was a little bit different. There were less kind of bars going down. So stable disease, can be either a 29% decrease in the sum of target lesions or a 19% increase. And as you can see, when I look at the waterfall plot, that's important to know, because if you see more of it going down, that is more clinically relevant. So in a patient with pancreatic cancer, if you have a CA19-9 going down and you have a 20% decrease in sum of target lesions, I think that's very clinically and radiographically meaningful in that sense. So the response rate, I think, doesn't tell the whole story, but these patients did have a response. So at week 14, 20% of the patients had a response, and that kept on going. So these patients, actually what happens is when you treat them, they get the stable disease and they slowly go into a response. And as you can look at, the overall response rate for 20 plus week was 27%. The only approved agent in pancreatic cancer in second line is 5-FU-onivide or liposomal irinotecan, which has a response rate of 16% in their trial and about a progression-free survival of 3.1 months. So that's important to know in the context of these data. Then when you see a 27% response rate, this drug is doing something. And like I said, 5 years back, if you told me a pill that patients with pancreatic cancer could take, when we talked about tumor microenvironment, the shield around the tumor, so hard to penetrate, I would never have believed them. I said, you always need a chemo combination, but these were very heartening results for our patients. And the overall observed progression-free survival, and this was, as I said, was the money shot. The KRAS G12X, that's any G12 mutation. As I said, the progression-free survival for patients after frontline pancreatic cancer patients is 3.1 months. When you look at Gem/Abraxane data, it's even less probably than that. But the progression-free survival, again, single arm, phase 1 was 8.1 months. So dramatic improvement from what we see with our patients. And for all RAS mutant pancreatic cancer, it was a 7.6 months. So these were definitely, important results. We really, honestly, in the pancreatic cancer community, we really haven't seen these results, even with chemotherapy or other targeted agents. Treatment-related adverse events, the big one is rash. As Scott was saying, if you combine these agents with EGFR monoclonal antibodies, toxicity is definitely a concern. Majority of patients do get a rash, but about 6% get grade 3 or greater, and you have to try to obviously mitigate it early. Diarrhea, nausea are two other side effects that we see, and these are important because we are going ahead to combine these agents with chemotherapy. And as you know, our chemotherapies, FOLFOX, 5-FU-Onivite, FOLFIRI, they all can cause nausea and diarrhea. So it's important to kind of see what that combination will look like. This was the overall survival. Again, it was the median overall survival was not reached in these patients. And this is the trial design for the RASolute 302. Clever play on words. The key eligibility criteria, again, confirmed PDAC, 1 prior line of therapy in the metastatic setting, ECOG 0 or 1, and patients are being randomized 1-on-1 to either RMC-6236, 300 milligrams POQ day, or investigator's choice of chemotherapy. Again, the primary endpoint, because most of the data from the company is in KRAS G12, so that's going to be the primary endpoint to see the progression-free survival and overall survival. But then all the patients are going to be also, when reported out in this trial. So this is, remember Sylvester Stallone, so kind of followed it up with, I think hopefully people have a lot of concerns. These are not durable, but hopefully, the durability we'll see in these trials. But there is definitely hope. I can tell you how many patients fly into Anderson or come to other centers which have these open, trying to get on these trials. It's a truly unmet need. And it's really, I had a patient who came from Georgia, and I was the 4th stop in their road tour to try to get onto the trial, the phase 1. So patients know about it. And it's the first time that we're seeing something unique in pancreatic cancer. So we really hope this pans out. Obviously, early days, we'll see the phase 3 data. We'll have to look at the durability of response, how to improve them. There is a lot of, the future